Hi, boys and girls. I'm Dr. Pooja Arora Bhatnagar, your mentor from Just MRCOG. Today, I'm going to discuss about obstetric anal sphincter injuries care bundle. In England, the rate of obstetric anal sphincter injuries has tripled over last decade, from 1.8% to 5.9 among single-term cephalic vaginal births. Overall incidence of OASI in UK is 2.9%, with an incidence of 6.1% and 1.7 in primary and the multiparous women respectively. Main risk factor for anal sphincter amongst childbearing women is OASI. Each care bundle element is applied to every patient every time. Remember, each care bundle element is applied to every patient every time. OASI care bundle is composed of four evidence-based interventions that, when performed together and supported by an educational program, may reduce rate of third and fourth degree tears. If it comes as SD and your junior wants to understand, or if your consultant is asking about OASI care bundle, this would be your introduction. The care bundle describes the evidence-based components that, when implemented together, improve the reliability and quality of care related to OASI prevention. The guidance is compatible with clinician discretion and doesn't replace reasonable clinical judgment. And when they say clinician, it means obstetrician and midwives both. As with all aspects of maternal care, appropriate consent should be obtained prior to use of any intervention of OASI care bundle. It's a very important patient safety point. This guide is intended for use by all midwives and obstetricians using the care bundle during labor. Clinician must be aware of the risk factor for sustaining an OASI, including nulliparous, South Asian ethnicity, birth weight more than 4 kg, shoulder dystocia, occipito-posterior position, prolonged second stage of labor, previous OASI, and instrumental delivery. It should be remembered that even without these specific risk factors, a woman may sustain an OASI. So, therefore, care bundle should still be applied even if a woman doesn't have any risk factors which we mentioned for sustaining an OASI. Again, this is a very important patient safety point. Now let's discuss elements of OASI care bundle. As I said earlier, it has four key elements. First, inform the women about OASI and what steps can be taken to minimize her risk. Second, when indicated, episiotomy should be performed mediolaterally at 60-degree angle at crowning. This is a very important information which you may need to give to your examiner or your junior at the time of any ST. Third is documented use of manual perineal protection, that is MPP. For spontaneous birth, manual perineal protection should be used unless women objects or her chosen position for birth doesn't allow MPP. But for assisted birth, MPP should be used. So remember, for assisted birth means when you are using instrument, manual perineal protection should be used, though for the spontaneous birth, if women objects or the position is not favorable, then you can skip. Number 4, following birth, perineum should be examined and any tear graded according to RCOG guidance. And very important patient safety point is that examination should include upper rectum check even when perineum appears intact. And this should be documented in case notes. So these are the 4 elements of OASI care bundle. Now, when we need to inform women about this care bundle, during her antenatal appointment, which takes place between 32 to 36 weeks, women should be given a copy of OASI care bundle information leaflet. These are available in assessment units, ultrasound departments, and consultant-led clinics. Clinician may be concerned that there are positions that will not allowed to use manual perineal protection, like if women is laboring in water or on a birthing stool. Any other position should allow for attending clinician to visualize the perineum and use their hands to support at the time of birth. As always, communication is very important as per college rule. Clinician has particular concern about a women individual risk for OSI, as we have already discussed about risk factor. They may wish to recommend that women adopts a position that allows for MPP to apply during birth. So as clinician, we may recommend for a position which is allowing us for MPP. And this discussion and women's decision for her birthing position should be documented in maternity notes. For example, how we are supposed to document. We have suggested manual perineal protection, and now how you are going to document in women's maternity notes. If patient agrees for this, then you are going to write patient name, that Zeni is aware of OASI care bundle. She has no objection to it being used if she is in a position for birth that facilitates use of care bundle. Or if patient refuses, Jenny is aware of all elements of OASI care bundle and rational for its use. However, Jenny declines its use because she objects to an element of care bundle and or prefers to adopt a position for birth that doesn't facilitate the use of bundle, like birthing stool or water birth. Whenever indicated, episiotomy should be performed mediolaterally at 60-degree angle at crowning. This is our second part of OASI care bundle. We have already discussed the first element, that is to inform women and document her wish. Episiotomy should never be a routine intervention to reduce risk of OASI. Should only be carried out after clinician assessment of fetal and maternal risk. Indication for an episiotomy, if you are giving or you have given, should be recorded in women's notes. Again, very important patient communication and patient safety point. In the context of this care bundle, episiotomy is indicated in case of fetal distress, delayed second stage of labor, instrumental delivery, in cases where a severe perineal tear is judged to be imminent, like feel digitally for remaining space or stretch and observe whether blood flow to perineum appears significantly reduced. I repeat, in care bundle, episiotomy is indicated in case of fetal distress, delayed second stage of labor, instrumental delivery, in cases where a severe perineal tear is just to be imminent. And how we do it? By digitally checking remaining space or stretch and the blood flow to the perineum. There is a must use of episiotomy if all term forceps ventus birth in nulliparous. In multiparous women, an episiotomy should also be used for all term forceps birth, but may occasionally be omitted with a ventus after considering and discussing women risk of sustaining OASI. I hope I'm clear that for all nulliparous, any kind of instrument, we offer episiotomy. But for multiparous, we offer for forceps, but not necessarily for vacuum. Episiotomy is always performed at the time of crowning and performed at 60-degree angle on women's right. So right mediolateral 60-degree angle at the time of crowning. Again, second point, how you are going to communicate. We should always, as a clinician, communicate the indication to women. When episiotomy is used, clinicians should assure that they document the indication for episiotomy. Very important communication with colleague and patient safety point. Angle at which episiotomy was performed and the women's agreement for episiotomy to be used. So you are going to document indication, angle, and women's agreement. How you are going to document. For spontaneous birth, manual perineal protection should be used unless women is chosen for any position which is not allowing or patient objects. For assisted birth, we always said that manual perineal protection should be used. Now, what is manual perineal protection? Manual perineal protection is a bimanual technique that requires support of posterior foreshead with one hand and cupping of fetal head with other hand to prevent head coming out with great force as it progresses at crowning. We use Finnish grip technique for MPP. FINNISH. Finnish grip. This maneuver must be used in combination with appropriate coaching of maternal breathing and reduce pushing. Very important. When you are doing MPP, you have to advise patient for breathing and reduce pushing. Now we'll discuss manual perineum protection in spontaneous birth. Now let's discuss manual perineal protection in spontaneous births. It is necessary for clinician to gauge the speed at which head is progressing to allow the use of appropriate pressure. Pressure should enough to allow progress but prevent uncontrolled expulsion at the correct time, and that is crowning prior to birth. One hand is used to cup the fetal head and control the speed and progress of presenting part, and the other hand supports the perineum using thumb and forefinger on the lower part of labia, and the firm pressure is used while flexing or curling in the remaining three fingers and pushing them against perineum. As the face becomes visible, use the middle finger of perineum support to assist with the birth of chin over the interosseous. I repeat, as the face becomes visible, use middle finger of perineal support hand to assist with birth of chin over the interosseous. Encourage the mum to refrain from pushing and breathe the baby out slowly. Very important that mum has to refrain from pushing while baby head is delivering. Wait for restitution to occur, still supporting the perineum, and encourage the mum to push gently to birth the shoulders. Once head is delivered, restitution occur, then mum has to push gently to birth the shoulders. Remember, continue MPP throughout the birth of the shoulder by moving your non-dominant hand to support the baby's body, applying gentle axial traction until both shoulders are born. Now, important principle for manual perineal protection: coaching the mom to avoid sudden expulsive pushing, maintaining gradual progress during birth of head, no undue toward traction during delivery of shoulder, undue downward traction during delivery of the shoulders, support the perineum throughout the whole birth. Very important. Support the perineum throughout the whole birth. Allowing access to perineum is necessary for achievement of manual perineal protection at crowning. MPP is not limited by women's position. It can be used in position including semi-recumbent, lateral, and all fours, that is on hands and knees. Now let's talk about assisted birth. MPP should also be used during assisted birth when using either forceps or vacuum. In these instances, the technique of MPP may have to be modified. I'm going to post some images how to use MPP during instrumental birth. If two clinicians are available during an instrumental birth, the assistant will apply support from one hand on the perineum during the birth of fetal head, including after the episiotomy has been cut by the instrument of choice. On crowning, the clinician should control the speed of birth of head. If only one clinician is available, it may be possible to use one hand to support perineum and use the other to operate instrument, provided this doesn't risk harm for the women or baby. Now, how to communicate. It's recommended that women are encouraged to slow their breathing and control their pushes on crowning in the anticipation of birth of the fetal head. So when we ask women to slow down her birth and they control their push on crowning, anticipation of birth of fetal head. This allows the perineum to accommodate gradual stretching caused by head, thereby reducing the risk of tearing by uncontrolled expulsion. Fetal head should never pop out. Pop out word is a buzzword. It should be guided in a controlled manner at crowning with a combination of controlled, slow or shallow maternal breathing and reduced maternal pushing and MPP. So how we deliver head? Controlled manner at crowning, combination of slowed or shallow maternal breathing, reduced maternal pushing and manual perineal protection. If maternal effort is not proving effective, women should be given additional positive encouragement to try to facilitate the birth of the baby, but again, control must be maintained throughout the birth. If an instrumental delivery or birth is necessary, women will need to adopt the position required to successfully facilitate instrumental delivery. If clinician has particular concern about a woman's individual risk of OASI, as we have already discussed the risk factor, they may wish to recommend that women adopt a position that allows MPP to be applied during birth. This is a very important patient communication and patient safety that we have to communicate to keep patient safe. Unless the baby's condition is critical, the once head is born, clinician should wait for the restitution of head, that is external rotation, and then the internal rotation of the shoulder. That means great care should be taken during the birth of the shoulder and the MPP should continue as the shoulders are delivered. Baby's body should be born following the direction of the curve of Carus. Using gentle axial traction, maternal effort, avoiding undue downward traction, MPP should continue if possible during the birth of shoulder. And how we document this? I, Dr. Arora, applied manual perineal protection during crowning of baby's head. Jenny agreed to this intervention and was in, then mentioned the women's position for the birth. Any difficulty while applying MPP should be documented. Last but not the least, the perineal examination include a perineum per rectum examination carried out in all vaginal birth. Very important patient safety point. Perineal examination including per rectum examination. Following birth, a thorough examination of perineum should be carried out. A very important patient safety point. It is recommended that a competent clinician assess perineum following every vaginal birth. And the assessment must include rectal examination as recommended by NICE guideline number 19, and we should categorize or classify tear as per RCOG guideline number 14 and should document in case notes. And clinician should explain women importance of doing the MPP or any kind of support or episiotomy. Verbal consent must be obtained for examination. So now here we are talking. In each step we have discussed basically 4 steps, and each step we have to communicate and we have to document. This is something very important. Verbal consent must be obtained for examination. Women should be comfortable. Educate analgesia, a position where optimal visualization of the perineum for assessment. Women's dignity must be maintained throughout. Clinician must be willing to stop if asked to do so by the women. The women's agreement, interventions, postpartum discussion, all should be clearly documented in notes. Together with examination finding and follow-up plans. Again, very important patient safety and communication. Women's agreement, whatever intervention you have used, like episiotomy or only MPP, it should be documented. Postpartum discussion about this, examination finding after delivery, and whatever follow-up plans you have given, it has to be documented. How you are going to document? I, Dr. Arora, have performed a postnatal perineum per rectal examination and have found then we have to list tears and degree, and I communicated this with Jenny. This is how we document about whatever intervention or if perineal tear has happened. This is the 4th element of OSI care bundle. So there are 4 OSI care bundle. Each point or each element you have to discuss or communicate with women, and then you have to document. This is all about OSI care bundle. Now I'm posting certain pictures which are depicting how we do this manual perineal protection in various birthing positions. The first one is recumbent or semi-recumbent. The very first position which you can see. In second picture, this is a lateral position while delivering. So MPP in lateral position. Third picture is all fours or hand and knees position, as we have read in shoulder dystocia. Just see how we give protection and delivery of baby's head in a very controlled manner. Now MPP while using forceps. The fourth position is for same. So these are four pictures about that. Last picture is about applying ventus, how we protect baby's head, how we give perineal support. Perineal care bundle can be a very important task as college is now very adventurous and they are giving all, which may sound very small, not very important for you, but they are giving these kind of tasks. So be very careful that you have to read everything, whatever is given in Asyogi, especially any topic which is related to patient safety or avoid any kind of complication. This is Dr. Pooja Arora Bhatnagar, your mentor, signing off for today. Bye bye. Take care.